Welcome, everyone, to today's webinar, the HR plus Finance Operations Best Suited for Automation. I'm Laura Dierda, Editor-in-Chief at Becker's Healthcare. On behalf of Becker's Healthcare, thank you for joining us. Before we begin, I'm going to walk through a few quick housekeeping instructions. We will begin today's webinar with the presentation and panel, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. If at any time you don't see your slides moving or have trouble with the audio, try refreshing your browser. You can submit any technical questions into the Q&A box. We're here to help. With that, I'm pleased to welcome today's esteemed panel. Anna Toomey is a Senior Solution Advisor at Blue Prism, America's public and private healthcare SME. Anna Toomey has dedicated a lifetime to providing transformational health IT solutions for national and international healthcare markets, both public and private sector. Anna has a master's in IT from MSU, and her career has been dedicated to creating solutions to complex problems in healthcare using intelligent market-leading technology since 1995. Anna joined the team of Blue Prism because she saw the tremendous value that Blue Prism's RPA technology brings to healthcare and recognized the ability to truly transform the healthcare enterprise with RPA. Anna has worked with some of the greatest technologists, scientists, clinicians in public and private sectors since 1995. Her list of accomplishments is extensive and includes such titles as Chief Analyst for Foundation Health Federal Services, HIE Solutions Owner at Dell Corporation, Chief Investigation and Administration Manager for Bioterrorism Preparedness at the City of Houston, and a private consultant and healthcare SME for multiple organizations. Anna has served on the advisory boards for the CDC, NIH, and CMS. Anna is a member of Blue Prism's Women in RPA. She has been featured in multiple Women in Technology publications, received recognition awards from Cambridge Who's Who Registry of Executives, Professionals, and Entrepreneurs, and was recently nominated for induction into the Female Moguls in Engineering Foundation. She is a leader, advisor, entrepreneur, and private consultant to organizations across the industry and around the world. We also have Duff Glazer, Senior Director of Healthcare for Blue Prism, America's public and private healthcare SME. Mr. Glazer is a 35-year healthcare professional. Previously, he was with SAP Software for 10 years, where he led the healthcare LOB with a focus on ERP, analytics, driving solutions around patient engagement, new payment models like ACOs, value-based payment, value-based contracts, and evidence-based care. Anna and Duff, thank you for being here today, and I'll now turn the floor over to Duff for the presentation.
Thank you. Thank you very much for the kind introduction. Everybody, as I just recently stated, my name is Jeff Glazer. My friends call me Duff, so when you ask some questions, please refer to me as Duff. I'm very excited today to talk to you about intelligent automation. Some of you might have heard about RPA, robotic process automation. It started about 15, 20 years ago. And that really was the onset of business process automation, which really focused on having software robots, also known as digital workers or bots, that were able to look at processes, repetitive, structured processes that individuals were doing. So if you think of somebody in a hospital that might be doing claims management and revenue cycle, that person would be doing the same repetitive motion time in and time in again around checking to make sure that the coding is correct, that the diagnosis is correct, that all of the information being sent on to the payer is correct. Well, in many hospitals today, they are using digital workers or software robots to do that. RPA has evolved, and that's why we're talking about intelligent automation today. Intelligent automation is really the coupling or the marriage of automation, artificial intelligence, and machine learning. It's really the three technologies that really bring a dynamic solution to bear for organizations such as yours, hospitals, that are really trying to focus on cost savings, revenue savings, et cetera. By automating processes across revenue cycle, supply chain, patient care, HR, and other administrative tasks, you're able to build in efficiencies and build accuracy, build in the ability to make sure that your error rate is low so you do not get the claims denials. It does not affect, let's say, cash on hand on day, because you're just not making the errors, because the robotic digital workers are in essence providing you with 100% accuracy. This is very, very important, especially today, as we see a lot of the challenges that hospitals are addressing post-COVID and revenue that's lost because of the close down of operating rooms, et cetera. We really look at healthcare automation from an enterprise perspective. And I think it's really important for everybody to understand that Blue Prism doesn't look at it just from an administrative standpoint, but we look at automation, intelligent automation, and how it affects the patient. How do we make sure that the patient is satisfied? How do we make sure that the patient is safe? And how do we help providers deliver the most positive outcome possible? And we do that by having these digital workers perform functions, and Anna is going to go into the storyboards around different functions that are very, very important to the patient, to the provider, and to the organization. But most importantly is that the patient will have what I would call a physician advocate, a patient advocate, that holds their hand through their healthcare journey. And we're going to talk about that. Today, what's very, very important for everybody to understand is that we're looking at intelligent automation in the HR and finance world today, because in HR, we know that one of the challenges for hospitals is how fast we can bring on physicians. If we listen to the news today, we understand that hospitals are in serious shape, negative shape, because of a lack of personnel. And that ability to bring on caregivers in a timely fashion is very important. We know historically, sometimes because of credentialing and other issues, that it can take upwards of 6 months to bring in a physician or a nurse practitioner or a PA. Utilizing a digital worker to help with that credentialing and HR administration, we can knock that down to a few weeks. And think about what that means, A, from a revenue standpoint for the hospital, but also B, from a patient care perspective. And then, of course, in finance, the viability and sustainability of an organization is paramount. And I would ask that you look at today's presentation around digital workers as your third workforce inside of your organization. And this is a workforce that can work 24/7, 365 days a year, and streamline and drive efficiencies across your organization. And those are two of the most important aspects of our presentation today. There are a lot of challenges in healthcare, and as you can see on your screen, an awful lot of time by caregivers is spent in front of their screens doing administrative tasks. That's taking time away from the patient. We want to give that time back. We also know, as we work with over 2,000 hospitals in the United States, that 60% of healthcare operations can be automated. And we at Blue Prism have put together some fantastic storyboards with hundreds of automations that can be benefited to organizations. So I'm not going to read this slide for you, but there's huge savings to be had just in the automation. But on the revenue side, one of the most important aspects is hospitals have to worry about losing their patients. When I say losing their patients, I I mean to say that these are patients that are going to leave their network and go to another hospital for their care. This phenomenon called leakage is extremely important because if you think of a patient in their life cycle, they're worth about $600,000 during their life to a hospital. And if that patient leaves, and historically we know hospitals in general lose about 10% of their revenue annually to leakage, patients leaving the network, then you can imagine a $3 or a $5 billion hospital losing $300 million, $500 million in lost revenue. For a small regional hospital, that might be $50 million to lose 10%, $5 million of their revenue due to leakage is catastrophic. It's terrible. So we look at the way that digital workers can interact with patients as well as providers to make sure that that patient experience is as positive as can be, and that's the most important. With that introduction, and I hope you now have a little bit of a better understanding of RPA and intelligent automation, I'd like to turn it over to Anna Toomey, and she'll take you for a drive through the rest of this presentation, and then we'll be there to answer some questions afterwards. Anna?
Thank you, Duff. I appreciate that. So I want to start with maybe talking about what the digital workers are. Sometimes people say, what is Blue Prism and what is RPA or what is intelligent automation? And why do you call them digital workers instead of bots? Well, the reason we do that is because, as Duff mentioned, this is part of a third workforce, a 24-hour digital workforce that works completing jobs that are mundane, redundant, and prone to error throughout the organization. And today we happen to be talking about the operations life cycle, which includes everything from patients and clinicals, but primarily operations, financials, and leading up into rev cycles. So you'll hear me talk about a lot of that. But a pool of digital workers that work either from a cloud or on-prem, we have various different ways of deploying the digital workers, can actually take on the jobs and roles and responsibilities from any one of those categories that you see across the stage. Everything from managing incidents to doing credentialing, and we'll talk about that one in particular today, and completing rev cycle, checking eligibility of benefits for patients, as well as checking licensure for the physicians that are treating the patients. And they're interchangeable, multitasking, and for example, whenever I say that, let's say we have 5 digital workers, and one may be performing scheduling, one may be performing payment posting, one may be doing order entry, denials management, physicians onboarding, or patient onboarding. At the same time, maybe one of them is, the queue is queued up and there are larger processes going through, so we need to offload some of that information to Bailey, who was doing payment posting. She's completed as a resource for the day, but there's still time on that digital worker, since you have 24 hours a day to use that person. There's no breaks, no special holidays. So this is like bringing on an employee that doesn't have to take breaks, holidays, or smoke breaks, that continuously does these processes. And they interchange, off-change, which frees up your actual staff, who was normally in those positions, to do more care coordination, case management, working directly in disease management, doing more lab testing, or working with the patients directly. So that's a little bit of an explanation about what digital workers do, how they manage these tasks, and moving forward. So I'll talk about operations today, and what falls actually in the operations storyboard. And this is just an excerpt of our storyboard. We wanted to give you a flavor and feel of all the different types of processes that we have by categorization. And what falls under our operations storyboard are things like assisting human resources, assisting quality management, assisting utilization reviews, inventory management, regulatory requirements, and regulatory reporting. We've got a lot of use cases with a lot of different hospitals that use us strictly for gathering information to assist in legal services or in incident management, never incidents that happen or occur. There's a lot of legal back work and backlog that has to be done. So giving that to a digital worker to assist in gathering all of that information assists very quickly in satisfying the necessary paperwork for those use cases. But actually performing human resources is what we're going to focus on a little bit today. And this is, as Duff mentioned, things like bringing new physicians on, credentialing them, ensuring that their licensure is up to date, that they are qualified by the facilities to not only work with the patients, but to work with them in the capacities that they're designated, and then to bill on them efficiently. This process takes quite a bit of time whenever you look at it, just according to statistics. Generally, there's around 18% turnover ratio within hospitals and healthcare. With the pandemic and the high turnover ratio that has come with that, physicians being sick or demobilized and unable to attend, new physicians being brought in that have to be credentialed and licensed and brought on board. The general turnaround time is 100 days to onboard a single clinician, which, whenever there's an impasse and there's a large influx of patients, that can become very costly. Not only that impacts the saving of lives in those categories. Misbilling, because you start billing too early for a physician who hasn't been properly credentialed with the insurance agencies. And that becomes a backlog of denials that turns into an even bigger space that's already overpopulated. So looking at 100 days of onboarding clinician time and 20 days to offboard a previous physician that is retiring a physician, the total cost for just one physician, and we're not, I've grouped kind of the clinicians in this, but I brought this down to just the cost of a single physician, is around $1 million. And that's whenever you're bringing in the costs of not being able to bill for the physician that's leaving or offboarding and being able to bill for the new one, as well as losing patients during that time zone that the new physician is coming on board, and you're having to disperse the existing patients out to the clinical staff that is available. So getting that downtime from 100 days of onboarding time down to a reasonable number so that we can get more physicians onboarded and much faster, bringing that 20 days down to 10 days on the offboarding so that there's a much quicker transition period, is very cost effective. And we've found this with working with a lot of our customers, such as Mass General Brigham, working with Mount Sinai, with Kaiser, with Banner, Kettering. There's several different customers that have actually, they focus strictly on, or they started their focus in on financials and HR. But so we've been able to, save a lot of dollars in those particular areas for our customers. Some of the things that we do to get that down to a lesser amount is to reduce that 100 days down to 30 by looking at staffing deficiencies and our digital workers starting to auto-post new positions as they become available. One of the demonstrations that I had that was rather lengthy, and I didn't want to take up too much time in demonstrating that, the digital worker actually gets receives a request for a new position that's going in. They load that information in, they pull all the criteria that matches that particular physician or position title, input that information, and load it all up into Salesforce and into Oracle PeopleSoft, either position, whichever one your company has. And then it auto-posts those to the web so that it starts actually doing soft recruiting for you. The digital worker does all of this. And it repeats that process. It checks it, it validates it, it manages it for up to 60 days, and then resends out for approval if the position hasn't been filled, and gets additional approval from the hiring director or the hiring executive for those positions. And it keeps all of your information up to date consistently, and everyone abreast of what positions are available, which ones are being looked at, who is, has actually been onboarding, what is our retention ratios, looking at recruitment and acquisition. So things, actual physical things that the digital workers do are things like sending out offer letters or looking at new hire paperwork. And I'll show you an example of a digital worker actually bringing in new hire paperwork and loading that information into your system and monitoring that incoming paperwork and then setting up first day's business for that new clinician that's coming on board. Some other things we do is check licensure verification, set up credentialing with the insurance providers, and set up renewal dates on those verifications, just to make sure that everyone is properly credentialed and can be actually working with the patients. So this is an example of a use case that we recently had, Healthcare Holdings. The process is that we brought it down from a 45-minute process down to just 1 minute with 100% accuracy and returned all of that time back to the staff. A new starter that was joining the organization, the candidate enters their details into the HR system, and a digital worker reads that information, does a cross-check, does a validation, does a background check. It adds individual payroll information in, it updates the next of kin and updates emergency contact information, adds the address, and puts everything into the system to onboard that particular clinician. And I have a demonstration of that, which I will share with you now, and I'll come back in as soon as this demo shows. This is how the digital worker is checking new hire paperwork, inputting the information into the system. An email has arrived at a digitally monitored mailbox with attached rehire paperwork. This begins the process as the digital worker scans the documents to ensure all required fields have been completed. Notating each missing piece of required documentation, the digital worker then returns documentation to the candidate, utilizing NLP to request missing fields of information such as date of birth, social security number, current postal code, and primary contact. The rehire inputs the proper information and resubmits the document through email. The digital worker again reviews the attachment for missing fields of information and, notating that all fields have been completed, proceeds to next step of the onboarding process. The digital worker prepares a cover letter in both Spanish and English and emails the welcome letter to the employee with attachments. The digital worker then logs into Salesforce and inputs the employee's personnel information, including demographics, contact details, payroll, and compensation information, hire date, job title, and more. After completing all the necessary inputs in Salesforce, the digital worker saves and closes the employee management portfolio. Next, the digital worker emails the facilities manager to request a desk and facilities badge for the employee. The digital worker emails the IT department to request a laptop with signature requirements for the employee and gives the date of hire. The digital worker emails payroll with appropriate ACH documentation for payment processing, including the routing number and account number. The digital worker performs cleanup and returns to email monitoring mode. Hopefully that's on pause.
Healthcare organizations want to be hyper-focused on delivering the best care and the best service.
Let me pause that again. I think we passed a screen prior, so I'm going to go back. An email has arrived. An email has arrived. This is the one I need right here. Let's push this one out so you guys can see this one. Okay, so next we want to talk about, and hopefully you guys can see the right screen before I actually show this one. The next demonstration that I was going to show you, or am going to show you, is how we actually verify licensure by checking with the state registries to make sure that the new clinicians, that whether it be an RN, an LVN, or a physician that has been licensed with the state, has been properly credentialed in the system and is able to, hasn't missed any C&E credits or anything. The nurses have to go through additional training just like us teachers do. We have to go through additional C&E credits every year to make sure that our licensure is up to date, and then there may be an expiration on it every 2 years. But there's a verification process. So once this process here that you see is set up, then it can continuously check for HR all of the licensure that may be up for expiration that month. It can notify the lead nursing director. It can also notify the actual clinician that is in the process of updating their licensure, and it makes sure, it ensures that you're all within legal compliance on all of those different areas. So in this particular case, we're looking at 3 new clinicians that we want to check their licensure, verify with the state, and then move forward with that. So let me bring that one up. So we have 3 nurses here, and we're going to check their licensure number with the state registry. So the digital worker logs into the state website, puts in the number and information for that clinician, makes a copy of the licensure to show that it's valid or delinquent, holds on to that information, goes to the next one in queue, verifies that one to check for delinquency, checks the next one in the spreadsheet. We had 3 of them to check, so the digital worker is going through that process, captures a screenshot of each one and saves it as a PDF. Then it will open an email and email both the clinician that it just checked the licensure on, as well as the director, to let them know how many within their organization are currently needing to be licensed. Here we've attached the PDF to the email. That one goes out, and then to the lead director in HR. They will receive a list of all in their organization that have been checked and verified. So this is just one of the tasks that we do in HR to cut down on any kind of legal discrepancies, to meet obligations for state. But while we have just a couple more minutes before I move into this last video that I was going to show you, some other areas that we actually aren't showing demos, but I wanted to mention that these are some of the areas that we have deployed applications for all of operations. Everything from roto planning updates and having the digital worker pull all the information for those, sending bed rotation reports, food planning updates for your food departments, requesting capacity reports, and uploading those to the proper command centers, daily command center updates, creating contracts. I know this one is really, really prominent during this time that we've been going through pandemic, and the need for creating new contracts because some of the other contractors have retired or businesses are no longer in operation. So we're bringing on new contracts for food contracts, for utilization of services in your facilities area, incident reporting logs that need updates for any never incidents or unreported incidents. Another area is regulatory compliance and regulatory reviews. We've utilized digital workers to do that. We've had digital workers that collect information and complete all of the steps in a state review to verify that all the items have been met. We have one particular customer that saved thousands of hours of time just by automating that one single report. That was one of our customers. Incident reporting, managing state and Fed violations, so that if state comes in and checks for any discrepancies and you have to mitigate those risks, then digital workers can verify that those have been done and submit your results back to the state. Patient data transfers, if you're going through a transition, if your IT department's going through a transition, maybe you're transferring from a Cerner shop to an Epic shop, and there's a lot of transition there where you've got to move patient records and verify patient records. Digital workers can move patient records from one system to the other directly as a human would, as if you were bringing in an entire staff of humans that were sitting there and verifying each patient record before it's moved to the new system. We can set that up with digital workers as well. So these are some of the areas and operations that are currently in process and able to be utilized daily now. We're happy to come in and do a full demonstration of any of those that I've mentioned. For this last demo or last video, before we go to answering questions and share some information with you in that manner, this one is for credentialing. And as you know, the credentialing piece for physicians is not only checking their licensure, but being sure that they are properly credentialed with the payer organizations that they're going to be billing from. And that's another list of criteria that has to be fulfilled each time we bring on or on board a new physician. So this is a demonstration about how we handle that process, and it's from our corporate office.
Healthcare organizations want to be hyper-focused on delivering the best care and the best services for their patients, but distractions arise. An average annual turnover rate of 18% for healthcare professionals is a big distraction, and it's costing the healthcare industry $200 billion a year. But thanks to Blue Prism's robotic process automation, that's changing. Blue Prism is working across the healthcare sector, automating away stressful, frustrating, time-consuming, and repetitive work processes. Processes like inefficient insurance billing that prevent timely services such as labs or treatments. Processes that take nurses and physicians away from their patients. Processes that take HR away from employee engagement and recruitment. Blue Prism and its partners are helping healthcare organizations build a work environment that empowers their workforce to focus on their patients and avoid endless piles of redundant paperwork. No more distracted caregivers. That's a competitive edge in today's healthcare system. Physician licensure is a good example where automation can play a critical role. Government regulations require healthcare systems to monitor and update clinicians' licensing and credentialing status, but large HR systems can be continually burdened with the many manual steps it takes to check and update credentials for hundreds of affected employees. This is critical work, but mistakes often happen. Expired credentials can go undetected, risking costly fines, potential liabilities, and ultimately, trust. Blue Prism's robotic process automation significantly improves the efficiency and quality of the licensing and credentialing verification process. By intelligently cross-referencing hospital caregiver records with online credential registries, the digital workforce identifies expiration dates and updates HR systems accordingly. This vital process runs in the background. And when license expirations are upcoming or credentials must be updated, emails are sent to the caregiver, and their HR representative is alerted, giving the clinician ample time to address the renewal and keeping HR up to date on the renewal process. This is Blue Prism, reducing risk, increasing confidence, and keeping the focus on the patient. As intelligent automation and AI increases healthcare quality and lowers costs, how will you capture its value?
We'll open it up for question and answer time now, and I'll turn it back over to Duff. Thank you, guys.
Thank you very much, Anna. I hope what everybody was able to take away from Anna's presentation was simply the fact that automation today is a much broader and bigger picture than what we started with several years ago with RPA. Intelligent automation is now looking at full workflows and how those workflows impact the organization. So when conversations start around viability, sustainability, digital workers, automation, and the pairing with artificial intelligence, machine learning, now gives you viable, proven tools. I think one of the things that we really haven't touched on is return on investment from these type of technologies. There are organizations out there saving tens of millions of dollars per year by utilizing digital workers. And it's not the fact that digital workers are replacing full-time workers. It's that they're augmenting it. And I think Anna alluded to this, and I did too, that you're getting a third workforce. You're able to take manual tasks away from specific workers and give them more complex and challenging opportunities to grow. And we're seeing this across hospitals. So with that said, we look forward to answering your questions and trying to provide you with some more value.
Thank you to our panelists for a great presentation today. We're now ready to begin today's question and answer session. You can submit any questions you have by typing them into the Q&A chat box you see on your webinar console. Let's get started with the first few questions. And the first question we have here is, data privacy is such a huge issue in healthcare. How do you adequately protect patient information when utilizing intelligent automation?
Anna, would you like to touch that? I know that you've answered it before.
Right, and I'm always happy to take that question because it's one of the things I get most excited about, using digital workers to perform these types of tasks. As part of my internship, I was part of building out the HIPAA Act, or the Health Information Protection Act, and so I'm very familiar with the requirements that it takes in there, and that's been cumbersome over the years for us to maintain. How do we keep strict guidelines on the utilization? How are we not exposing PHI and different rules around the workplace that we have to adhere to just to protect that? So when I noticed that RPA is digital workers, so it's information that's never being exposed to the screen. It's all done by robotics, which are non-human and not interfered by human during the process. Once you've set the process up, it's a continuous process. It's going to repeat exactly like you set it up initially. We have PHI extrapolation, which actually masks anything should it be in transition. We also have encapsulation so that security in transition of information is not exposed. Being able to execute these steps in blind mode, or headless mode, as some would call it, or unattended mode, actually keeps any of it from going to screen. So you're not exposing your PHI, you're not storing your PHI in another location, and it's non-human workers who are dealing with it. So it's not like they have a human intent to utilize that information in any way. So another thing that makes me excited about that process is the way we back up logs. We have irrefutable logs reporting of every step a digital worker takes, every record that they've accessed along the way, and how they've managed that data in the process. So you can pull those reports for a state log at any time. So those are kind of exciting ways I also like to answer that question.
Thank you, Anna, so much for going through that with us. That was a really, really helpful explanation. Now, I have another attendee question here. Can you utilize intelligent automation to build an agile, transformative environment in healthcare?
I think I can answer that. So the answer is yes, you can, because I think where RPA has evolved from being in a very rigid, rule-based technology when it started. Today, now with artificial intelligence and machine learning, you've added that agility to the functionality of a digital worker. And this allows for the focus on workflows instead of just single processes. So we can now look at a workflow and automate it, and then also add artificial intelligence so it could be more prescriptive in the way that it addresses things. This is very important if you think about it, the agility aspect of it, as to how a digital worker can partner with a patient at that virtual door. And as that digital worker learns more about that patient and what that patient is going through on their healthcare journey, it can direct the tests to different stakeholders. It can put information in a multitude of hands in a very timely fashion, thus increasing its functionality and viability to make sure that the patient journey is more satisfactory, more safe, and hopefully for a better outcome. So I hope that answers your question.
Thank you, Doug. That's really helpful to know. I do have another attendee question here for either you or Anna. What is a realistic timeline for a medical center to realize savings using the digital workers?
I think both Anna and I can answer this. So, from a cloud-based standpoint, we could stand up in the clouds in several days. And if you want to look at a singular process, maybe in revenue cycle, you can get a very fast, probably within 30 or 45 days ROI on that. We have organizations that have taken specific workflows and processes and automated them, using multiple digital workers, standing them up in the enterprise on premise, and they have realized very strong ROIs in less than 6 months. So it depends on how you would like to deliver that, either via the cloud or on premise, and what is the scope of your initial project. Anna, do you have anything to add from there?
Yes, I absolutely agree with everything. Only one thing that I would add is a use case with one of our customers that has actually been, they took on several processes, and within less than 3 years of time, they're already saving hundreds of millions, just by automating the processes. So they're seeing a very hardcore return on investment over a 2 to 3 year period. Short-term implementations, you can see very fast, very hard numbers come up, as Duff mentioned. But if you look at it as a long-term engagement with multiple processes, maybe an entire revenue cycle or an entire HR process, those things like that, you see even larger bulk. Those are annual type savings. So you're going to be seeing anywhere from 10 million to 100 million type of savings in just those short periods of time.
And for our guests on this webinar, if they would like to direct message us, we're more than happy to provide you with not just success stories and references, but we can also show you through a specific ROI calculator how we've identified approximately 10 workflows that we can look at, and based on the size and scope of your organization, we can run some very conservative numbers for you to show how the automations in one case, revenue cycle, can be realized in a very short time period with a large number. So we're available to do that at your request.
Gus and Anna, thank you so much. That has been such an interesting response, and Anna, I really appreciate your use case explaining that there. That was so interesting to hear. I have a further attendee question. How much IT and ops effort does it take on average to customize one or your established workflows of digital workers?
I have an answer. Anna, would you like to start?
Okay. The customization process it depends upon the systems that you have deployed at your location. In most healthcare organizations, there is a specific EHR that is prominent throughout the organization. That may be a McKesson, a Cerner, and an Epic shop. So the customization depends upon which workflows that you're working with and the systems that you're working with. It may be PeopleSoft, or it may be an Oracle application in your finance department that needs to be plugged in, but those determine exactly the layout. So those are the types of customizations that you would need to plug in after you've initially established the workflow itself. Does that answer the question? Was there a second part to that question? Was there a time exactly around it?
Yeah. But just wanting to. Oh, yep. Know how much of the IT and ops efforts does it take. So it seems like, you've provided a pretty comprehensive look at that. Duff, did you have anything else to add?
I think one of the things that people are coming to realize around intelligent automation is that these low-code and no-code software digital workers can be set up very, very quickly. And you don't have to be an IT person to do that. And that's the whole idea between low code and no code programming. So, and again, we can define that and talk specifically to workflows and processes if somebody would like to.
That's really good to know. And we do have several other questions that have come in, so I'm excited to continue the discussion here. The next question I have for you is, can you please explain about how Blue Prism platform is integrated with payer, provider, and HR portal?
Sure. Anna, I think that's right in your wheelhouse.
Yeah, that's one of the things I'm excited to talk about. Provider and payer portals have a user interface. A lot of them have user interfaces, so the digital workers can interface directly with the user interface to request your referrals, to request your eligibility and your authorizations and your patient information. But more excitingly, we're starting to see many more that are doing API connectivity, which allows the digital workers to do a direct connect. So something as simple as moving directly from your EHR to request the authorization. If you're in an Epic system or a Cerner system, you can send out an electronic message that connects directly to the API at the payer organization. Their digital workers, which are becoming much more prominent in the insurance industry, to have answering bots on the other side, can actually pick up those requests for authorization, complete them, and get them back to you in record time. For years, we've kind of gone back and forth on that battle of how many hours is it going to take for us to call in an authorization on this procedure based on it being this particular payer company or that particular payer company. That time has diminished to at least 50%. Just by the use of digital workers actually, logging those in the portal. But secondarily, we are now starting to see, up to the minute type savings with being able to go API to API and having digital workers answer on both ends or bots answer on both ends to complete those authorizations and referrals, et cetera.
Got it, Anna. That makes a ton of sense. Thank you for going through that with us. Now, another attendee has asked, can you please explain how health insurance claim denial is handled with Blue Prism in case the platform encounters one of the, those claims due to a missing provider credentialing process in the payer portal?
Yes, I can explain a little bit about that. It's much better demonstrated in a revenue cycle. But as the claim is, or I have a storyboard called Day in the Life of the Claim. Actually tracks it going directly from the provider portal over to the payer portal and the questions that are asked and how we mitigate those risks. As it loops back through, the digital worker has a process for aligning those claims to whether they need more information, whether they need additional coding checks or different missing information. Each one of those buckets is then picked up by a different digital worker that pulls that information back from the system, inputs the information, resubmits the claim. So that becomes an automated process at that time. Instead of having to involve analyst or, someone working denials management, the digital worker becomes your denials management rescue at that point, so that they can actually input the information or attach additional patient information, verify the CPT or the ICD. Sometimes a CPT is missing. A EKG came in after the request went out for a particular authorization, such as angioplasty or something like that. So it's going to bounce back. It's going to say, is this a CHF? The digital worker can confirm that in the record keeping, put that information in, and send it back out. This is the speed with which the digital workers are able to operate, especially if ones like Blue Cross or UHC are actually using digital workers on their side to respond as well.
That's good to know. Thank you so much, Anna. And it's such great information that you're providing here. I know this is extremely helpful for our attendees. The next question that has come in here is, how can the Blue Prism system augment utilization review for insurance?
Utilization reviews for the insurance side by gathering information and setting the appointments and setting up the review process between either the clinicians and or the utilization staffing. There is a process that says, we need to gather the patient records and all the identified information from the system and be able to have all of that information available for all reviewers in the panel, or if there's just a peer review, peer-to-peer type utilization review. So the information is gathered by the digital worker from the system, as well as I had a demo that would actually show it collecting any kind of digital information, any kind of imaging information that would be helpful to the case. And then as it submits that to the reviewers that are assigned, it also sets an appointed time and meeting place for that review, so that you're not spending a lot of time chasing calendars between the different attendees that need to be able to review that in depth and schedule a time for it. So the digital workers actually do the scheduling to help initiate that review as well. Hopefully that answers your question. Thank you.
That was a very comprehensive response and really, really helpful for us. Now, the next question I have here is, changing healthcare policies pose a great challenge for automated portals like Blue Prism. Can you please explain how changes owing to the policies or any other issues that come up, how they will be brought to the Blue Prism platform?
Yeah, let me set Anna up to answer this. So if you think about what's just occurring now with price transparency that's being mandated to payers and providers, Blue Prism is very well positioned to help those portals update immediately, because really all you need to do is put in a digital worker that has been programmed for that data, and it will go out and seek that data, which is the pricing and everything, and then post it to where it needs to be posted for transparency. So I think that is a current day challenge that I think a lot of providers are looking at, is how do we put that information out and in front so our patients and customers can see it. Anna?
Yes, that's a very good example of a current day issue with the fee schedules not being up to date in the systems, and being able to have a digital worker go out, capture the fee schedules, and update the table so that we have transparency across the board, and your physicians are up to date on all costs for those plans. That's a very good example of one of the ways that we're assisting in updating and most recent policies. Another thing is maybe interoperability standards that are ever changing, it seems, and the ability to communicate with FHIR, which is something that our digital workers do well. But one thing to keep in mind is that at Blue Prism, we handle things a little bit differently whenever it comes to how we set up our digital workers. The descriptions that I showed you are the demos that I showed you actually showed the workflow to the right and the actions taking place to the left. But what you didn't see to the right is how we interact with those applications on the left. We build our digital workers to be resilient and the most scalable in the industry by positioning business objects as part of the process. We build business objects that go against the systems you're going to utilize, and then we build repeatable processes that continuously utilize those objects. So if a policy change comes up that maybe redirects where the digital worker needs to go first, we just change the object location, the object once, and all the processes are back in order. If it's location wise on the screen or something like that. If it's a single process change, maybe they need to grab another piece of information. It still is familiar enough with the system by using the object that it's also only one change that has to happen for all the other processes to fall back into play. So it's a much better technology way to handle those particular quick changes.
It's great to hear how flexible and quickly you're able to do that. Thank you, Anna and Beth, for going through that with us. Now, we have a couple minutes left and a few more questions as well. Our next attendee wrote in, you talk about how much you can cut credentialing time down, but haven't addressed how long those submitting items for the process or the time it takes to privilege a provider. Could you provide comments on those items?
Okay, actually, in the credentialing process, the longest time that it takes is on the side of the payer organization. I will take UHC for an example because they, and Athena as well, they both have credentialing portals that are probably the most used by our digital workers. The ability to capture the information for the physician is almost everything that's within the first initial onboarding package, which you saw that the digital workers can just extrapolate that from a DocuSign or from the contract that the doctor sends over. So most of that information is easily accessible. Then it's time to enter that information into the portal or in through Availity, which also provides a portal service capability to submit electronically. The digital worker can log in there and input the information. It is the length of time that it takes for the payer to come back with their success ratio that actually determines how much time we can save. We can turn that process into a fluid flow, which only takes minutes versus hours and days that we were having to do before it, gathering all of that information. But it is on the side of the payer that it determines how quickly the response comes back. And we're starting to see that time go down drastically as more and more payers bring digital workers into their credentialing process as well.
Got it. Thank you so much, Anna. Now, I believe we have time for one more question, and the final question is, what system does RPA use, and does it have open capability with other systems?
Okay, it is a software platform, a very secure software platform, Blue Prism Software Enterprise. And we do connect with, whenever you say open systems, there's various different ways we approach that. We have API to API connectivity. We connect from open API to API. So if you're setting up an API portal at your payer organization or provider organization, then we program those endpoints into the digital worker so that they can communicate between the two. So there's a yes and no answer to that. We're not an open source platform as far as the software goes. It is very secure, very scalable, and private software application, but we do have open source capability of communicating between API.
Got it. That's very helpful to know. Thank you, Anna. Then I do have one point of clarification too, from slide 9, in terms of the cost for onboarding. Is it $1 million to onboard or $100 million? The slide says $100 million, but we just wanted to clarify that in terms of where it goes. So if you could clarify that, and then we'll round up here.
I did note that question, and I'll have to go back and look at that slide. It is 1 million to onboard normally, okay, and 100 days. I think that's probably where that came into play. If the slide says 100 million, then I apologize. We will correct that. But it's a normal onboarding process for a physician is $1 million, and we definitely want to bring that down by, getting them onboarded much more quickly, as well as cut down back on those 100 days to 30 days.
Well, thank you so much, Anna and Duff. That is all the time we have for today. I want to thank our speakers for an excellent presentation and Blue Prism for sponsoring today's webinar. To learn more about the content presented today, please check out the resources section on your webinar console and fill out the post-webinar survey. Thank you for joining us today, and we hope you have a wonderful afternoon.
Thank you.
Thank you.